And we're going to get started again. Once again, just a reminder to please fill out your surveys before you leave. We do take that information into account. So now I'm really excited to present Dr. Alexander Baumgartner. Dr. Baumgartner is an assistant professor of neurology as well as in the Department of Neurosurgery. He's a board certified neurologist and he has fellowship training in movement disorders with a focus on deep brain stimulation. His clinical expertise includes the management of movement disorders, including Parkinson's disease, atypical Parkinsonism, tremor, and other movement disorders. And his research interest is in non-motor Parkinson's symptoms, with a particular interest in how these symptoms might be affected by advanced therapies such as deep brain stimulation. And so he's going to talk about that today. And please welcome Dr. Baumgartner.
Thanks very much. Can everyone hear me okay? Is the microphone working? The back? Good. Okay. Thanks very much. Yes. Closer. You got it. This. Just keep going through these. Okay. Oh, there we are. Great. Thanks very much. My name is Alex Baumgartner. I'm pleased to talk with you today about advanced therapies for Parkinson's. Just a couple of disclosures to let you be aware of. We do receive funding from the companies that produce some of the devices we'll be talking about. So by way of a brief overview, I'm going to just mention briefly a few highlights about Parkinson's disease symptoms. We'll talk about medications very briefly. I know you already heard a lot about that. And then we'll move into advanced therapies. So I probably don't have to tell you that Parkinson's disease is a neurodegenerative disease resulting from a loss of dopamine neurons in a part of the brain called the substantia nigra. It's slowly progressive, causes both motor and non-motor symptoms. And the treatments that we have are symptomatic, meaning they alleviate or treat symptoms, but don't necessarily slow or alter the course of the disease. The treatments we'll be talking about are advanced therapies. These are generally for people with advanced Parkinson's, but what exactly advanced Parkinson's means is not exactly clear. There have been a lot of efforts to define advanced Parkinson's disease. One way to think about this is that motor complications or motor fluctuations have developed despite optimized pharmacologic or medication treatment. And some of the most common motor fluctuations or motor complications that we talk about are fluctuations, so varying disease states or varying levels of symptoms throughout the course of the day and night, as well as dyskinesias, which are involuntary movements often caused by levodopa or other Parkinson's medications. Early on in Parkinson's, people experience typically very little in terms of these fluctuations and dyskinesia, and the gap or distance between too little medication and too much medication is very wide. But as the disease progresses, the brain continues to lose those dopamine-producing cells, and it can become more difficult to adequately control symptoms with medications. And people might experience fluctuations or dyskinesias, both when medications are too high or at their highest level in the body, and when they're too low, or when the medications wear off and feel like they stop working. As time progresses and the disease progresses, that distance between too little and too much medication can become narrower and narrower, and people might experience more and more fluctuations and complications. Just to give you a little bit of statistics, there was at least one study that tried to estimate how common these fluctuations and complications were over the course of the disease. They found that in a group of people with Parkinson's, a little over half developed motor fluctuations, so that would be medications wearing off earlier after a dose of medication. Over half of people had developed those fluctuations about 5 years after the onset of their initial symptoms. And by 10 years, everybody had fluctuations. Looking at dyskinesias, they found that 15% had developed dyskinesias after 5 years of Parkinson's, and just over half had developed dyskinesia over 10 years after their journey with Parkinson's began. And so this gives us some sense of when people might be eligible or might be appropriate for advanced therapies to address these complications. But of course, every individual with Parkinson's is different, and the timing may vary a lot from one person to another. Parkinson's, at least at the onset, is typically managed primarily with medications. Here's a whole long list of medications available for Parkinson's that you already heard all about. But like we said, people, as the disease progresses, might not be able to control symptoms as well with medications. And then we start thinking about advanced therapies. There are a few different advanced therapies that we'll talk about. The first are alternate ways or alternative ways of getting medications into the body rather than taking something by mouth. One that's been available for just about 10 years now is called Duopa. At least in this country, it's called Duopa, but is a suspension of carbidopa-levodopa, the same ingredients in Sinemet, delivered into the gut via a tube rather than taking pills by mouth. Like I said, this has been around and approved by the FDA since 2015. The drug goes right into the gut, and so this helps minimize the amount of medications that people have to take by mouth. Also allows the brain to receive a nice, consistent, and constant supply of medication because the medication is pumped in continuously over either 16 or 24 hours rather than taking a pill, which gets you a big dose of medication that then can wear off several hours later. What's involved for someone that might be interested in this treatment? First is the placement of the tube called a PEG tube through which the drug is delivered. There's some education that has to be done on how to manage the tube, how to clean it, how to attach and remove the cassettes that carry the drug itself. Like I said, the brain sees a constant supply of medication, and we know that this will help minimize fluctuations, improve off time or time when symptoms are not adequately controlled, and improve on time. This is a figure from one of the original studies that led to the approval of Duopa, demonstrating that essentially the on time throughout the 24-hour cycle is improved on average by about 4 hours per day with a similar reduction in off time. Complications or side effects of Duopa largely relate to the device itself, and they usually happen early on after the device placement. But they can include problems with the device insertion or it falling out, infection around the insertion site, and other GI symptoms like abdominal pain, constipation, nausea. Again, those things are common earlier on and definitely or typically improve after a couple of weeks and increased familiarity with the device. A more recent development has been the development, of a subcutaneous system for delivering carbidopa-levodopa. So rather than a larger surgically inserted tube into the stomach and small intestine, this is a very small needle that a patient or a caregiver can place themselves right under the skin of the abdomen to deliver carbidopa-levodopa, much like an insulin pump would deliver insulin to a patient with diabetes. Similarly to the studies that led to the approval of the Duodopa, the studies leading to the approval of the subcutaneous carbidopa-levodopa have demonstrated that people's on time typically improves by about 4 hours per day, with a similar reduction in off time of about 4 hours per day. This device is currently undergoing some back and forth with the FDA. And so the company that has developed this doesn't yet have FDA approval, that we expect that sometime soon this will probably be approved and then subsequently available for treatment of Parkinson's. I'm going to move on now to talk about neurosurgical treatments for Parkinson's. These involve treatments or delivering therapy to relevant structures in the deep down parts of the brain, including the subthalamic nucleus or STN, the globus pallidus or GPI, nodes in the brain where we think a lot of the pathological brain activity that leads to Parkinson's is developing or passing through. I'll just mention briefly some older and less commonly used advanced or lesion therapies for Parkinson's. These were some of the first surgical treatments developed and discovered for treatment of Parkinson's, but they all involve essentially making a lesion or a injury in a part of the brain that disrupts some of the abnormal circuitry that's producing Parkinson's symptoms. One of the first ways that was done was via a radiofrequency ablation. You can see here a probe that's gone down into one of the parts of the brain that I mentioned just a moment ago. It delivers a radiofrequency pulse, which essentially destroys a small piece of tissue. Due to some improvements in technology, this is less commonly done, and I'll show you some examples of newer technologies. Gamma knife radiosurgery is a radiation treatment that does the same thing. So without delivering or putting a probe down into the brain, uses radiation to create a small lesion in the brain. We know that it does improve symptoms like tremor, but it carries risks in the sense that radiation can cause delayed effects and expansion of that lesion in the brain. And so that can lead to other symptoms caused by the destruction or interference in nearby brain structures. And that can include problems with vision, weakness, speech changes, sensory changes like numbness. And so for those reasons, this is a not commonly done procedure anymore. A procedure that's received a lot of attention in recent years has been MRI-guided focused ultrasound. This is same idea, create a lesion or a scar in the brain in a pertinent part of the deeper brain structures, but doing so without inserting anything into the brain or without risk of delayed complication. The process essentially looks like this. You can see on the right visualization of the skull with surrounding it what are 1,024 individual sources of ultrasound. When those sources of ultrasound are focused on a single spot, they combine essentially to create heat, which will then heat up and destroy the relevant piece of brain tissue. And so what you're seeing in the schematic on the left are doctors looking at essentially an MRI of a patient's brain using what's called thermometry, or a real-time visualization of the heat changes induced by the ultrasound machine, and then looking at successive changes in people's symptoms with this treatment. We know that it's effective. You can see from these graphs that tremor, for example, in this study is reduced by 50 to 60% or sometimes more in the treated side, and that benefit is durable. It seems to stay around. Some side effects of MRI-guided focused ultrasound, again, are due to involvement, usually from some inflammation at the time of the procedure of nearby brain structures. And that can cause things like paresthesia or numbness and tingling, imbalance or trouble with coordination, and muscle weakness. These are more common at the time of the procedure, where anywhere from 5 to 15% of people might experience some of those symptoms, and generally improve as the inflammation and swelling that's caused by the procedure improves. And so as time goes on, these symptoms generally improve, typically within a matter of weeks or sometimes months. This therapy has been approved by the FDA to treat first essential tremor, and then more recently, tremor-dominant Parkinson disease, both of those being treatments to the thalamus, a part of the brain that's highly involved in tremor circuitry. And then even more recently, possibly being approved to treat Parkinson's disease, although that still is an ongoing issue of whether that treatment in a different part of the brain, the GPI, will be covered for Parkinson's disease. But this is an approved treatment for essential tremor as well as tremor-dominant Parkinson's disease. Some things that are worth considering for someone who might be interested in an MRI-guided focused ultrasound would be whether the procedure can be done safely and effectively, and that really hinges on a few anatomic characteristics. We will need to know before the procedure the density of someone's skull. You can imagine that someone with a very low density of their skull might allow for ultrasound waves to essentially reverberate in the skull, and that can limit the efficacy of the procedure because we can't focus the beam of ultrasound on a single spot. It can also make the procedure much more uncomfortable or painful. People who already are bothered by some of the other symptoms or possible side effects I mentioned from the procedure may not be good for this, such as someone who has a lot of trouble with walking and balance, because that certainly can be made worse by the procedure. Someone who's unable to lie still in an MRI machine, perhaps due to claustrophobia, would not be a good person for this procedure. Someone that already has metal in the body that can't or is not safe for an MRI machine obviously would not be good for this procedure. I'll show you a little bit about a patient example of someone who underwent an MRI-guided focused ultrasound in our center. This is Mr. B. I'll show you a video in just a moment. He's a 71-year-old man. He's right-handed. He's had tremor, so essential tremor. This is a little bit different than Parkinson's, for more than 30 years. He's tried multiple medications to treat his tremor, but not had good success, and would hope to be able to do things like use utensils better, go back to woodworking, a hobby of his, as well as fly fishing, and is hesitant about DBS, or deep brain stimulation, having electrodes or a device inserted into the body. See if this will work here. There we go. So you can see he has a tremor of both his hands. That's obvious when he holds his hands out in front of him. You can imagine how this would interfere with his ability to eat, drink, do woodworking, fly fishing, tying flies. In the planning stage of the procedure, we use an MRI as well as a computer program that registers a patient-specific MRI to an atlas of relevant brain structures to help us visualize the part of the brain where we want to target with the ultrasound machine. Preparation for the procedure involves shaving the head completely, as well as placing a frame on the head to hold the head in a fixed position relative to the MRI machine, as well as this soft cover, which essentially allows for the device to fill with water to improve the sonication and the delivery of ultrasound rather than through air. An initial CT and MRI scan are obtained to help us plan the procedure. That lets us visualize any areas where it may not be safe to send ultrasound. For example, if there's a fold creating an air bubble in that device I just showed you. And we use on the right side this thermometry. On the bottom right, you see a heat map, essentially, so an automated visualization of the heat being generated by the ultrasound treatments. And we know, based on studies and experience with this, kind of the level of heat that's needed to permanently destroy or permanently create a lesion in the part of the brain that we're interested in. During the procedure, the patient goes into the ultrasound and MRI machine several times to have a scan, to look at that heat map in real time. They can then come out of the MRI machine and for an examination, including an assessment of tremor. And we expect to see, as we do successive sonications or treatments lasting usually a minute or less, improvements in their tremor. And so this is Mr. B's drawings of spirals and lines that he did during the procedure. And you can see before the procedure, he's got a very severe tremor that almost makes it impossible for him to draw or make a straight line or sign his name. During the procedure, so about halfway through, you see some definite improvements, though the tremor is still there. And by the end of the procedure, there's very little tremor at all. Here he is again the next day. Remember that only one side of the brain is treated. So his right hand has essentially no tremor here. The left hand, which was not treated, still has the same tremor. This is a fairly recent procedure. And so you'd wonder, well, is this going to last? Will this still be effective for me several years down the road? We're just starting to now get data on longer term follow-ups on this procedure. But looking at people 5 years out from the procedure, we still see that their tremor improves by as much as 70% for holding in the hand in a posture, between 40 and 50% for improving during other activities, writing, pouring, etc. And we know that their quality of life improves as well, even 5 years out. So could you do the same thing for Parkinson's? That's been studied as well. Specifically in the GPI, or the globus pallidus interna, with the goal of alleviating not just tremor, but other Parkinson's symptoms, including stiffness and slowness of movements. And that's the reason for the selection of a different target, a different part of the brain. And so this is called a pallidotomy, or making a lesion in the pallidum, or GPI. There does seem to be some strong evidence that this is a therapy that can improve Parkinson's symptoms. One area of caution, I think, is that if you look at the left-hand figure in that first column, the gray shaded area is essentially non-responders. These are people who underwent the treatment and had minimal to no response at all in their Parkinson's symptoms. And it's about 30% of people, which comparing to DBS is a much higher rate of non-responders. And so this is a real consideration and a potential area of caution for us in terms of performing this procedure to treat Parkinson's symptoms specifically. Now, we do know, like I said, that it's ineffective and can be done to treat Parkinson's tremor, but treating other symptoms, stiffness, slowness, et cetera, maybe a bit more wary about that procedure. It does seem to improve Parkinson's symptoms, though, in the people for whom it does work. Like I said, the main concern would be the non-responder rate. Side effects can also be a concern when we're thinking about this procedure for Parkinson's. Some of the most common side effects can include new dyskinesia, so the emergence of dyskinesia in someone that didn't have it before, and that's a real area of concern. For most people, this was a transient side effect if it did happen, but there were about 5% of people that had persistent dyskinesia after the procedure, even a year afterwards. So to summarize, some benefits of high-intensity focused ultrasound in Parkinson's specifically. This is an incisionless procedure. There's nothing inserted into the brain. Sometimes you hear the word non-invasive, and I argue that it is invasive in the sense that a lesion or a scar is being created in the brain, but there's no insertion of any device. It's outpatient. People can go home the same day of the procedure. You're awake for the whole procedure without the need for general anesthesia. We get real-time feedback and information about what's happening in the brain as we do. We see immediate results. The flip side of that would mean that we don't have the ability to go back and make further adjustments, changes, reverse or remove something. We also have concerns about whether this can be done bilaterally due to issues that people experienced several decades ago when these procedures were done with older techniques. And we saw high rates of side effects or problems in people who had bilateral procedures. We're just starting to get a little bit of data about possibly doing focused ultrasound for people with Parkinson's bilaterally, but more information is needed. And so with that, I'm going to move on to deep brain stimulation. Deep brain stimulation has been around since as far back as the 1980s and been approved in this country since the 1990s, and then 2002 for the treatment of Parkinson's disease. This number should say probably something more like 150,000, maybe 200,000 patients have been treated worldwide with DBS since that time. We know that it's effective. Similarly to some of the other studies I showed you, it improves good on time during the day by about 4 hours per day and reduces off time by about the same amount. It improves people's quality of life compared to medication management. It's effective in doing things like decreasing dyskinesia, allowing better and longer periods of mobility, improvement in quality of life, and allowing for people to reduce their Parkinson's medications by about half. It does not have an effect for other things like speech, swallowing, memory, cognition, balance, or other autonomic functions like control of bladder or bowel function, drooling. I'm going to talk about some keys to success. The first would be the appropriate selection of the right person, the right patient to undergo DBS. That depends on the correct diagnosis, the age of the patient. I would say that there's not a strict number for someone that's too old for DBS, although around age 80 and up, we may think more carefully about whether this is a safe procedure. How long someone had Parkinson's, and I'll talk a little bit more about that. The levodopa responsiveness, this is a key factor in the decision to undergo DBS. In general, symptoms that are improved by levodopa will be improved by DBS. So things that are not improved by levodopa are generally not improved by DBS, with the exception being tremor. DBS can do better than medications for tremor. So for someone that might be interested in DBS, what does the process look like? You go through an evaluation, including on and off medications, so that we can see the levodopa responsiveness of someone's symptoms. You go through detailed memory or neuropsychological testing, primarily to ensure that someone hasn't reached a stage of dementia. We know that they may not do as well with Parkinson's. You have an MRI to help us visualize the brain and plan the surgery. You meet with a surgeon, and at our center, you meet with a palliative care specialist. That is helpful in some of these things you see on the right side of the screen in terms of screening for other problems with cognition or mood disorders, ensuring that other treatments have been optimized, ensuring that someone has the right social support before they go through major brain surgery, and that someone has realistic expectations. They know what's going to improve with DBS, and they know what may not improve with DBS. In terms of timing, we're looking for someone in this window of the disease where they've struggled with those motor fluctuations and are bothered by dyskinesia or fluctuations despite several doses or several changes in medications. Some reasons that someone would not be a good candidate for DBS, as I mentioned, would be dementia. We know well that people who have dementia or significant cognitive problems generally struggle and may not benefit as much with DBS. Someone that has symptoms that may suggest a diagnosis other than Parkinson's, that would include severe autonomic dysfunction, which could be an indicator of something called MSA or multiple systems atrophy, for example. Someone that can't undergo surgery for some other medical reason, including other heart or lung issues, cerebral atrophy or a lot of shrinkage of the brain that may place someone at a higher risk of bleeding during the surgical procedure. A little bit about DBS systems and what we're talking about here. Essentially, the DBS has three main components: an electrode inserted down into the brain, into one of those structures that I showed you before, an extension cable that connects the electrode down to a generator, or essentially a pacemaker that sits near the collarbone and the chest. Some considerations we think about for someone that's undergoing DBS would be, what's the right target? What's the right part of the brain to put this DBS in? In general, these two commonly used targets, the STN and GPR, are more the same than they are different. But this is a conversation to have with your doctor about what might be the right location based on your symptoms. Some nuances of the surgical procedure would be, is it done awake or asleep, with a frame-based system or a frameless system? Does the team use microelectrode recording or image-based or direct targeting? Do they use directional contact electrodes or DBS systems? The answer to that one is essentially everyone now is getting a directional DBS device, meaning that the stimulation current can be steered in different directions to help optimize symptoms and minimize side effects. These are also things to talk with your neurologist and neurosurgeon about. The procedure involves the placement of a frame or frameless system, which again help keep the brain in a fixed location relative to something external, either the bed or this device here, which is called a frameless system that allows for more head movement during the procedure. Targeting involves the use and the visualization of those relevant brain structures on both an MRI and a CT scan, so that we can make a specific plan to arrive at the part of the brain we want to be in based on someone's own specific anatomy. Here you see a couple of members of our team, Dr. Ogeman and Dr. Thompson, doing exactly that. They're looking at someone's brain scan, making a plan about where exactly is the right part of the brain we want to be hitting with the DBS. During the surgery, an electrode is essentially inserted down through the skull into the part of the brain that we want to be in. In our center, a neurologist is in the operating room with you to help monitor electrical activity of the brain and to help gauge response or change in someone's symptoms in real time during the surgery. We listen to that physiological activity or electrical brain activity that gives us clues about the part of the brain that we're putting that DBS into. That looks like this in real time, where you can see someone that's obviously awake, undergoing surgery, doing movements, and looking at a computer screen there that's showing you a readout in real time of electrical signatures of the brain, which again, based on different parts of the brain, have different sounds and appearances. We can see after surgery where the DBS lead is and map that to someone's MRI as a final step or check that the DBS device is in the right location. And after surgery, people return to the clinic for a series of visits that we refer to as programming, which involves fine-tuning stimulation parameters to help optimize symptoms. We won't spend a lot of time on this, but there are several things that can be changed in the clinic to help optimize symptoms. I'll show you just one quick example of someone who's got a lot of tremor, as you can see, as part of their Parkinson's. Hey, thanks for sharing. And when the DBS goes on, there goes the tremor. Some side effects to be aware of in terms of DBS would include surgical risks like bleeding or stroke, infection. Generally, these are something that occur at a rate of 1% or less. There is a need possibly for subsequent surgical procedures, including battery replacements. Some other mood symptoms can arise as a result of DBS, and this should be something that you discuss with your neurologist after DBS surgery. I'll just mention briefly about some new things coming down the road in terms of when to perform DBS. Perhaps we should be performing DBS earlier, and that's generally been the trend. There's some data that's showing people's tremor may actually lessen over time the earlier they have DBS. We're incorporating new pieces of technology and information into programming, including some of that electrophysiology that we can record in the operating room to help optimize both surgical planning and programming. Different patterns and paradigms of stimulation may also help us improve symptoms while minimizing side effects. And then you may have heard something about adaptive or closed loop DBS. This is a DBS system that responds in real time to changes in physiological activity in the brain to, again, hopefully better control symptoms while minimizing side effects. I'll just mention here that at the university, we're very proud of our DBS program. We have the largest comprehensive movement disorders team in the region. We have a multidisciplinary collaborative effort between neurologists, neurosurgeons, radiologists, palliative care experts, a fantastic team of nurses and other support staff that help us treat patients with DBS and focused ultrasound. We have physicians licensed in Colorado, New Mexico, and Wyoming. We use all 3 available DBS manufacturers or devices. I mentioned some of the new DBS technologies and research efforts that are ongoing here, as well as around the country. And some unique aspects here that you've already heard about a little bit would be our palliative care team and neurogenetics team, which are integral to successful DBS treatment. With that, I'll say thanks very much, and I'm happy to take any questions.